Welcome to Introduction to Communicable Disease for NUR 107. I'm putting my PowerPoint up again on YouTube, and hopefully you will enjoy it as much as you did IV therapy. Anyway, we're talking about communicable disease, which is my favorite topic. This is my favorite lecture ever. And we're going to look into assessment of the immune system. So we're going to take a look at it. And here you've got the different aspects of the immune system, the anatomy of the immune system. You've got bone marrow. The WBCs are produced in the bone marrow from stem cells. The B lymphocytes are your B cells. So B lymphocytes, B cells. T lymphocytes, T cells. The B cells mature in the bone marrow, and the T cells mature in the thymus. That's why they're also T cells thymus and B cells bone marrow. So the B cells enter the circulation after maturing in the bone marrow. The thymus, the T cells, or they also start maturing. They develop in the bone marrow, but then they go to the thymus and they mature there into several kinds of cells. So you get your then you have your lymphoid tissue, which is your spleen, which acts as a filter, your lymph nodes and channels that drain foreign material before it enters into the bloodstream, and lymph nodes that proliferate immune cells. Excuse me. Then you have your tonsils and your adenoids. They defend the body's mucous membranes against microorganisms. Then you have your Peyer's patches, your lymphoid follicles on the mucous membranes of the small intestines, and then you have your appendix. Now, some sources, that they state that the appendix appears to have no function in the human body, but others, they say it appears to play a role in the immune system. Lymphoid tissue accumulates in the appendix starting shortly after birth, and it peaks in the 20s and 30s. Therefore assists in the maturation of white blood cells, specifically the B lymphocytes. It's also linked to the production of antibodies, immunoglobulin A or IgA, and it also protects good bacteria for the gut, as it's a reservoir for the good bacteria. So there's some dispute about the appendix, but that's one source. Again, some sources say that it does something, and some sources say that it really doesn't have a function. The lymphoid tissues on the bronchus, you have those. And per Lewis, they actually talk about the central lymph glands and the thymus, and is equal to the thymus and the bone marrow. Peripheral lymphoid organisms, your tonsils, gut, genital, and skin associated lymph tissues, lymph nodes, and your spleen. So that's in Lewis. Okay, so now we're going to go into, this is actually a document that I had posted in Moodle in my information about communicable disease lecture, and what I had to do is I had to scan this in sections and put it in my lecture for today, because I actually have some other slides coming up. That this is what took me some time, is the slides that I've created today are cards that I actually have from a conference that I went to a couple of years ago, and I showed them with the overhead camera, and I couldn't do that with this lecture, so I had to make some changes today. Anyway, so immune function and defense response here. I'm going to finish one more thing, though, about the B cells. So the humoral immunity, the B cells, antibodies, then you have bacteria, viruses, respiratory and GI pathogens, and examples, let's see, anaphylactic shock, ectopic diseases, transfusion reaction, and bacterial infections. That's all kind of part of that, and the memory cells. Lewis chapter 14, table 14.8, Lewis chapter 14, page 216. Table 14.8, they're excellent comparisons of the B cells and the T cells. The B cells would be your humoral immunity, and T cells would be your cell-mediated immunity coming from the thymus. Cell-mediated immunity T cells, they're sensitized T cells, or they're cytokines. They're fungus, viruses, intracellular, chronic infections, infectious agents, tumor cells, and examples would be TB, fungal infections, contact dermatitis, graft rejection, destruction of cancer cells, and memory cells. Now, I'm going to show you, we're going to go through this, and this is what I want you to really learn and know for anything in the tests. All right, what I'm showing you, the slide I'm showing you now, the immune function and defenses and responses. So you've got your two types of immunity. You've got your natural and your acquired. Your natural is innate, you're born with it. Your acquired is adaptive, so it's after birth. Natural immunity, the body's ability to distinguish self from non-self. The body uses physical and chemical barriers as well as WBCs or leukocytes and the inflammatory response to rid the body of non-self foreign material. Your physical barriers, your physical barriers would be, and we've talked about this before, and we talked about hygiene, and we talked about, excuse me, I have to cough. I guess I shouldn't have had milk with lunch. What are your first line of defense against infection? We talked about this in medical asepsis. So you've got your intact skin, your mucous membranes are going to protect you, your cilia and the respiratory tract are going to filter and help you to cough up things. You've got your chemical barriers. We talked about this as well. Acid in stomach secretions, which is real important for killing germs in food that you eat so that they don't hurt you. Mucus is going to collect material and call you cough it up, or it goes through your gut and your system. Enzymes in tears and saliva. You've got the enzymes in your tears that keep your eyes from getting infected, and in your saliva. Interferon is made in the body to fight viral infections as well. So you've got lots and lots of barriers that your body helps yourself to keep healthy. Your WBCs participate in both natural and acquired immune responses. You've got the two types of WBCs. You've got your granulocytes and your non-granulocytes. Your granulocytes fight foreign bodies and toxins and release histamine, bradykinin, prostaglandins. They engulf foreign bodies or toxins. Then you've got your granulocytes. Those include your neutrophils, for they're the first on site, your eosinophils and your basophils. Now, when you're looking at a CBC and you're trying to figure out what type of infection or response this patient is having, you're going to see the eosinophils or the EOs and the basos increase in allergic reactions and stress response. So that's something you look for in your lab values in your patients. As you get further along in your program, you understand more about lab values. Non-granulocytes include your monocytes, your macrophages, your lymphocytes, and that would be your B cells, antibody-mediated humoral response, your T cells, your cellular or cell-mediated response. You really want to remember that, okay? The B cells and the T cells, which is which, please, okay? And then your inflammatory response we talked about when we talked about wound care, and that would be your chemical mediators assist in the response to minimizing the blood loss right after you've been cut or had an injury, walling off the invaded organism, activating the phagocytes to get in there and chomp up all the bad stuff and take it away, and promoting formation of fibrous scar tissue, all your fibrinogens and all that getting in there to help to heal your scar. And then you have your obviously your 3 stages of healing, and you're regenerating your injured tissue. Okay. So now we have, this is just another slide on the bone marrow, your lymphoblasts. You get the bone marrow maturation, and then some of them go off the lymphoblasts, some go off to the thymus, and they are going to continue down to be your cell-mediated response, and those are your T cells from the thymus, and your B cells that stay in the bone marrow, they are going to go down to be your memory cells, your plasma cells, your antibodies, and then that's going to be your humoral response. So that just reiterates it. So these are just things I want you to know about. Okay. Now, this slide is actually an old slide, but I really like it. It talks about acquired types of immunities. This is acquired. So you've got your antigen and your antibody source. So you've got active immunity. This 2 here is supposed to be over there, and I can't change that, but it's just so you know it, okay? Your active immunity's antibodies are produced in the body by a response to an antigen, and you're going to have a long-term duration that's going to last a long time. Your natural antibodies are formed in the presence of active infection in the body, and that's lifelong. Now, your artificial ones, your antigens, which you get from vaccines or toxoids, are administered to stimulate antibody production. And you're going to get many years. The immunity might need to be reinforced by a booster, but it's going to be long-term duration that you'll keep this immunity, or this this artificial immunity will be there. Like when you get chickenpox vaccine, or you get a like for example your tetanus shot, you have to get that redone every 10 years because that waxes and wanes. But most of the other ones are finding, like the Hep B series, have done very, very well, and most people maintain that one for a long, long time. Your passive immunity would be antibodies that are produced by another source, animal or human. And those are going to be short-term duration. So one type would be the natural ones. Those are antibodies transferred naturally from an immune mother to her baby through the placenta or the colostrum in her milk, which is why breastfeeding is so important. And that's going to be your 6 months to 12 years is how long those are going to last. Once the baby stops breastfeeding, then you're going to stop having the immunity. You're still going to keep getting some immunity from the mother as long as the baby's breastfeeding, but the real boost is the what's in the colostrum. And then your artificial would be your immune serums, your antibodies from an animal or another human. It's injected. And that would be like, if you needed to get immune globulin, because maybe someone, example of that would be a baby that's born with a Hep B positive mother, and they want to make sure the baby doesn't get hepatitis B, so they will give the baby the immunization as well as giving them immune globulin so that they don't develop Hep B. So again, acquired immunity is acquired during life but not present at birth. Exposure to antigens through immunization or the disease itself, and it results in a protective response. And your two types we talked about, your active and your passive. Okay. There's a very deep explanation on page 212 in Lewis of acquired immunity if you care to look at some more. Okay, next slide. So now we're talking about assessment. What are you going to be looking at with your patients? You need a good health assessment. You need a good history of diseases and disorders. Now, back to your health history, it's going to include, if I had you in class, I'd be asking you to name off the things that what do you need to look at in your health history, and I'm going to have to read them because you're not there to answer me. So you've got your age. The elderly, their production and function of their T and B cells is impaired now, and you have decreased ability to respond to invading organisms. The very young, their immune system is immature, and they're not able to respond. So you got to watch those ages. That's the old and the young that tend to suffer and have more trouble with communicable disease. In your health history, you want to look at nutrition. Is a good balanced diet with vitamins are so important. Immunization and diseases of childhood, what did they have? They had recent immunizations. Did they have flu shot, pneumococcal, Hep A? Did they had a recent PPD? Did they have allergies to foods, drugs, or in the environment? So those are all the things you want in your health history. You also need a history of excuse me, I have to pause for a second. I apologize. Okay, sorry for the interruption. So then you want to look at disorders and diseases, particularly autoimmune disorders. And I'd be again asking you which ones, and you want to think of things like lupus and rheumatoid arthritis, psoriasis, the course of the diseases and the treatments that the patients are on, what medications they are taking and how is that going to impact things. You also want to look at neoplastic disease, which would be any history of cancer, dates, courses of treatment, courses, what course they were on, what treatments they received, screening tests, and family history. You also need a history of medications and blood transfusions in the past, especially medications that suppress the immune system. Those would be NSAIDs. You want to look at, do they have HIV, blood transfusion, blood products, especially, did they have blood transfusions or any blood products given to them, especially prior to 1985 when they started testing for these. Um, Lifestyle and other factors would be smoking, alcohol, diet, IV drug use, etc. And all of those things are going to affect your immune response. Um, and now you need to do a really good physical examination or physical assessment. Same thing, words are used interchangeably. You want to look at the skin and the mucous membranes. You want to assess. Oh, did I not go down? I didn't go down on the slide. I'm sorry. You want to assess. Good thing you have the PowerPoints available to you. The skin and mucous membranes, you want to assess them for lesions, inflammation, or any kind of infection. Now, what do you think would be problems like chronic illness and surgery? Particular diseases that would be chronic illnesses and surgery would be, well, say if they had diabetes, they had renal disease, they had abdominal surgery, recent surgery. You don't want to look at lymph nodes, joints, and special problems would be things like burns. Burns are a really special problem. So you're really, if your body's burned over a good amount of your surface area, it's open, and so you're going to have a very, you're going to be at risk for infectious disease. Psychological or physiological stress. You got to remember when you had your stress class that you have that cortisol being released, and it suppresses the immune response. Okay, now diagnostic evaluation. Okay, things that you're going to need to check. You do leukocytes and lymphocyte tests, humoral and cellular immunity tests, phagocytic cell function, complement component tests, hypersensitivity tests, and special antigen antibody tests. Examples of that, a lot of times I'll have to order that. I'll also say the HIV infection test, but the specific antigen antibody tests, I have to order those a lot for patients. Say I had one of you coming in when you were doing your prerequisites and you had to get your immunizations to start the nursing program, and you really thought you had the measles, or you had rubella, or you had the mumps. And so what we would do is but the most common one that I check for is usually varicella. So I'd order the blood test to screen for varicella titers, and they take a look at it, and you want to see that the patient has IgG for varicella, and that lets me know that you have been exposed, and so that you don't need to get the vaccine. So that letter of proof I actually printed out and handed to the patient, and the student or patient who has come to me to have this tested, and I say keep that for your whole life, because that is going to prove that you are already immune to this and you do not need the vaccine. So, if they were not sure, they needed proof of the vaccination or immunity, you get the blood test, and you can tell if they've been exposed and if they have immunity actually to this. Okay. So now management of patients with infectious disease. Guess what? Here we are. Actually, I'm going to go back to this slide I want to talk a little bit about, and there's really no slide for this, so management of patients. Who would you not immunize? So just take this information down, I'm sorry. The people you wouldn't immunize, as you all learned this past semester, is if you have an allergy to eggs or a particular immunization, you wouldn't want to get those immunizations. You wouldn't want to get a lot of immunizations they're grown in like an egg base, so they have a component of eggs in them, and that's why we are very careful to ask people if they have egg allergies. And some particular immunizations, like the DTaP, or as a baby, or even the MMR, they might have a high fever and a reaction to it. So you take a look at that. About giving them a repeat of that immunization. If someone has an allergy to eggs, though, very often they'll actually take their immunizations, or they'll get their immunizations at an allergist's office so that they can monitor them and make sure that they're safe. Now, what is another reason you would not immunize somebody? You would postpone, not immunize, but you'd postpone immunizing somebody that had a significant illness or a high fever, or had a fever. Someone had a cold and they came in, I'd still give them their immunizations. But if someone came in I wouldn't give them a flu, a Flonase vaccine, which goes up your nose, the liquid that you just squeeze up their nose. I wouldn't give you that one. The flu shot that it's not a shot, it's actually they inhale it, because that's a live vaccine and that would go into your nose and you have a cold. So I wouldn't, if you had any respiratory illness, I would not give you that one. That also, in fact, is contraindicated under a certain age, over a certain age, and also if you have any asthma, history of respiratory disease, or a history of cardiovascular disease, cardiac disease. But if you had significant temp or an illness, I'd wait a week or two and then return to office for that immunization. You also want to look at risk versus benefits and decide whether to give immunizations to a patient, especially if you had someone that, like an HIV positive child, and immunization. That's a real balancing act. If they're immunosuppressed either from chemotherapy, steroid therapy, HIV/AIDS, or progressive neurological disease, you're going to take a look at that. You also want to be very careful if you're giving chickenpox vaccine to a baby and there is a grandmother living in the house that has, or somebody living, a family member living in the house in close contact with the baby that has any kind of disease that warrants them to be on either chemotherapy or to be immunosuppressed and on steroids, because you want to actually give the information to the family and ask them to check with their the physician, usually the oncologist, to see if it's safe to give the baby these immunizations at this time, and you just hold off if it was not. You do not test for TB at the same time as you give an MMR. That's not a good idea. The measles can give you a false negative, actually. So these are things that you'd have to learn. Okay, let's go back to our friend, the chain of infection. So again, reviewing the slide, you've got your infectious agent. It's in the reservoirs, the portal of exit that it leaves the person who's sick that it's already developed into, and how is it going to get from that person to the other person, and it goes into your portal of entry, and that could be broken skin or whatever, and it goes in. But first of all, the patient has to be the other person has to be a susceptible host, because they're immune suppressed, they haven't had immunizations, they have chronic illnesses, they're elderly, or they're very young, or whatever, and then the cycle starts again. So what we want to do is look at how can we break that chain of infection, and we're going to get into that. One of the biggest ways you can do it is by giving immunizations and making sure your immunizations are up to date for you and your family members, including the older people in the family, and we'll get into that later. CDC and your OSHA, they're federal agencies involved in controlling and preventing infection. Your Mass Department of Public Health is a state agency, and then everybody has a local board of health in their town. I had some interesting personal experience with this because I actually took care of a family that the father, I think I might have mentioned this to some of you, but I can't remember. The father was taking care of the children. The mother was not home. There was a baby and a couple of other kids in the house that were, in the school-age children, and young school-age children, and the two older kids were outside in the yard playing, and a coyote came into the yard, and the family dog actually went to the coyote to keep it away from the kids, protected the kids. The kids were able to run into the house, but the family dog fought with the coyote. And when the coyote left, the family dog came into the house, and the father, of course, welcomed it with open arms, hugged the dog, and thanked it so much for protecting its children, and then could not remember if he'd washed his hands or washed himself before he picked up the baby. And because the kids were all hugging the dog too, and the dog actually had saliva on it from the coyote, and there was concern that the coyote might have been rabid or had rabies. So I called the local board of health in the town of Falmouth from the pediatrician's office I was working at, and then they referred me quickly to the state agency, who totally bumped me as fast as they possibly could up to the CDC. So I had a conference call with the CDC, and basically it was determined that because I could not 100% prove that there was no contact between the saliva and the baby, the saliva on the family dog and the baby, that everybody, the father, the two children, older children, and the baby all had to have rabies vaccines. So, anyway. That was interesting that day. All right, so this slide I already showed you about when we talked about it. I just put it up there again. Okay, now this is an example of an old immunization record, and the reason I show this to you is because the minute you post it, it becomes outdated and they come out with a new version. So I have the ability for you to access the newer versions. Um, I did want to talk a little bit about the difference between inactivated and live vaccines. You have live vaccines that would be like they're attenuated though, they're weakened, decreased virulence, but they still are live cells. They give a good immunity, it's a lasting immunity, and those examples of those would be your MMR and your varicella, and also your the flu mist. It's called the flu mist. Excuse me, the name wouldn't come to me before. The one that you take the liquid flu vaccine that's in the syringe, and the patient sniffs a little on one side of the nose and a little on the other. The beauty of that is they're getting immunized in the tract, the respiratory tract, or up their nose. That is how they're going to actually contract the disease if they can, get exposed to the flu. So that's why it's a really good. It's good to immunize the tract that you get it. That's why the Sabin vaccine, which was the oral polio vaccine used years ago, was so good, because it immunizes the gut, and that's how you're exposed to polio. You drink contaminated water. And the reason that we don't have the oral polio anymore is because one child out of many, 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 many millions actually got polio from it, so they took it off the market because that risk outweighed the benefits at that point, and we only give the inactivated, killed virus, polio virus now. So the inactivated immunization would be, it's generally need boosters. It's toxins. So like you've got your toxoid, will be your DTaP. Excuse me, your DTaP, which is your big D, big T, little a, and big P, which would be diphtheria, tetanus, and and the pertussis. Excuse me. And then you've got your inactivated polio, which I talked about already, and your Hep B surface antigen. So those are all inactivated vaccines. This is actually a hyperlink that goes to the CDC. If I do it during this type of a talk, it screws me up. But you can do it when you pull this up at home, and you have this lecture PowerPoint is in Moodle, and you can pull it up and you can go to this website. This just pulls up Centers, Center for the CDC, Control and Prevention, and it has a good article for you to look at. And this is all the updated, hang on one second. This one actually is the CDC vaccines that you can go to. This one actually is the American Academy of Pediatrics recent publication on the 2013 immunization recommendations. It's a very, very good article, and you can actually go to this CDC or go to the American Academy of Pediatrics or the APA and pull this up. Let's see. So what are some diseases that you need immunizations for? You've got your diphtheria, tetanus, pertussis, other Hib vaccine like the H flu or type B, which is a Hib. Causes a bacterial disease. It causes meningitis, pneumonia, and epiglottitis. Since we've had the Hib vaccine, I've not seen a case of epiglottitis, which is very wonderful because it was horrible to take care of those children when I first started in practice years ago. Because they actually had to go to the OR, be intubated, and then stay intubated until we were sure that we could extubate them, because you had to wait till the disease was better. Polio, pneumococcal disease, which causes meningitis and pneumonia. MMR, which is measles, mumps, and rubella. Varicella, Hep B, and Hep A we have immunizations for. Others that are optional vaccines would be for rabies, as I talked about a minute ago, only if you get exposed and need it. Your HPV, or your human papillovirus, which is your Gardasil. Smallpox and yellow fever, depending if you're traveling or need to have those. Okay. This goes to your CDC, the hyperlink for your immunizations, and you can go to this and you can get the current immunizations. Okay. Normally I'd go to these hyperlinks and would have done all this stuff, but I can't because it'll screw up in this program. So, communicable diseases. The incidence has declined with the increase of immunization, so we're really doing much, much better. People in this day and age really do not appreciate what an epidemic is. I guess one way to tell you about how to appreciate that would be to talk about, for just a minute, the H1N1 influenza, which in June 2009, the World Health Organization declared that a global pandemic of infection with the novel influenza A, or H1N1, because the virus, it was underway because of the rapid spread. It was not because it was a severe disease, because it wasn't for a lot of people. Some people got very sick and died from it, but most did not. But they did it because of the rapid spread of the virus to more than 70 countries. This new virus, this new H1N1 virus, first caused illness. It was detected in Mexico and the United States in March and April of 2009. The virus was promptly identified as a triple reassortant virus containing genes from human, swine, and avian influenza. Avian would be birds. Influenza A viruses in combinations not seen before. The kicker is that it took such a short time for this to travel worldwide. And I'm trying to find the slide that I have a card that talks about it in a CME program that I did, and it was very, very impressive. It was more because within a month it was widespread and in 70 different countries when they found 3 cases prior to that. So that just shows how our world, things can travel. You get on airplanes, you travel. It's just, if you ever went to that, I don't know if you've ever seen that blackened sky. It shows all the planes that are in the air at a given time, and it goes day, night, and just it's going across the Atlantic Ocean, the Pacific Ocean. It's very impressive to let you know how much travel goes on and how quickly a new infection could cause an epidemic. And it was a pandemic, actually, because it traveled so quickly to other countries. But back to communicable disease. So with the increase of immunizations, we've been able to stave a lot of this off, but people really do lack being part of the polio epidemic. And when people had measles and there was no vaccine for it, and people were very sick with that, or people were very sick with scarlet fever. Anyway, so it further decreased with the use of antibiotics and antitoxins. However, recently we're having obviously issues with overuse of antibiotics. The other serious risk now we have is because you have people are choosing not to vaccinate their children, and this is serious because we're going to lose the herd effect. And what happens is you'll have people that are of like minds in certain communities that will actually all want to not immunize their children. Mothers will talk to the fathers, will talk to each other, and maybe it's an academic group of like near a college, and they'll all be professors, and they'll think that they read everything they want to read, and they make this decision. And so what happens, you have these pockets of people that are not immunized, as opposed to just a few scattered around, because a few people, mostly it's just a few scattered around, but now we're having pockets of people. And mothers will say, oh, my child is fine, they don't need these immunizations, they're healthy, they'll fight it off themselves. And that actually, we'll get into this later, but that's actually not true. If you don't have immunity to it, it is going to hit you if you get exposed to it. And it's not the child's being healthy and not getting the immunizations that is protecting itself. It's all the mothers and fathers around them that have taken the risk and immunized all their children, and those children being immunized are kind of surrounding that unimmunized child, or just few immunized, non-immunized children, and protecting them from not getting the disease, protecting them from getting the disease. So the problem with having larger numbers not immunized, you're going to lose what's called the herd effect, with the parents' resistance to immunize their children, and it's going to become a real problem. In fact, we've had outbreaks of real problems in Washington State with, oh, here come the dogs barking again. They didn't want you to feel that they were being left out. I'm going to push pause. I think somebody must be coming to the house. Okay, sorry about that. again. So anyway, all right. So if the parents, they've had outbreaks in certain states. I think Washington State is one that has had real problems with measles and other issues. So. And then everybody runs around and has to get immunized and everyone has to get boosters because we're concerned about it. Um, okay, another thing I want to talk about is adult vaccine preventable diseases are not well addressed at all in primary care. And I'm going to go into a whole series of these cards that I actually usually show in the overhead camera, document camera in the smart classrooms. But I can't show them, so I had to scan them all in. And you will not have test questions on this. This is an appreciation for this and understanding of this because this is where things have to go. So this is a conference I went to a couple of years ago. And basically it's a call to action to take a look at the fact that a lot of adults are dying. Each year, millions of adults in the United States are hospitalized or require other medical attention as a result of vaccine-preventable diseases. I just want you to have an appreciation of this. 50 to 70,000 people, adults in the U.S., die each year from diseases for which vaccines are already available. So adult deaths account for 99% of vaccine-preventable mortality. When you think about vaccinations, you think about children. And if you look at children, that's 1% of vaccine-preventable deaths are due to children, 100 to 300 deaths a year in children. But adults, you look at this vast majority in this pie of 99 percent of the vaccine preventable deaths are 50,000 to 70,000 deaths each year in adults that there's no reason for it. And think of, for them to get to the point where they have to die, they've been hospitalized, they've been to the physician, they've been medications they've been on, maybe they were in the ICU, they most probably were. That is a very expensive added cost to healthcare for everybody, and it's a lot less expensive to just have gotten the immunizations. So I want you to appreciate that, and that we need to be more aware of this. Now, you asked what are the vaccine? I'm going to read them. The vaccines that are the illnesses that are preventable deaths because of vaccines that are available. So examples would be hepatitis A, hepatitis B, human papillomavirus or HPV. And we'll get into human papillomavirus later. Influenza, absolutely, that's like the biggest. The influenza related pneumonia is one of the biggest killers in the elderly population. I'll show you that later. Meningococcal disease, so your meningitis, meningococcemia, pertussis, your pneumococcal disease, your varicella. So that would be your chickenpox. And also that would include shingles as well, herpes zoster. Excuse me, I'm going to cough again. Okay. So one of the things to look at, this is a very impressive little slide here. It says vaccine preventable deaths. Vaccine preventable deaths in adults are similar to other important causes of death in adults. So look, you got colorectal cancer, breast cancer, that 40,000 people, breast cancer, prostate cancer, suicide, Parkinson's disease, HIV. Look at that. Vaccine preventable diseases in children, it's this little tiny little small amount. Look at how many vaccine preventable diseases in adults, and this compares them to breast cancer, prostate cancer, and suicide, and you see how many more people have died, and these are deaths that don't have to happen. So these are families that are losing members. Okay, now vaccines are for grown-ups too, and some of the things you really need to know is immunity can fade in the adults and they won't realize it, and that's why we had the problem with pertussis, and we've had outbreaks in pertussis with high school and college age kids, and they're the ones either taking care of the kids, meaning babysitting them, or even having the babies. So we wanted to make sure that they got re-immunized for pertussis, so that's why they mandated that everybody, all pregnant women get a Tdap, their spouses get one, and then they started with the next time everybody gets a tetanus shot, they should get the Tdap so that it has the pertussis in there to protect them. You have to remember, if a baby, because of their airway and the things that some of you have learned, half the class learned in their PD video, the respiratory video, is that the size of their airway, if that is compromised and they're coughing constantly, you really, really have a problem. babies who have pertussis, they can't stop coughing, and it always involves an ICU admission, especially if it's a baby that's under 2 months of age. So that's hugely expensive, and the baby can die from it. So I took care of a number of children at Children's Hospital when I was a young grad with pertussis up in Boston, because the babies had not had immunizations yet, and they were exposed to pertussis. So that's why there's been a big push to get that Tdap done. You got to remember, some of the adults were not vaccinated or were incompletely vaccinated when they were children. And you have to remember that some vaccines, a lot of vaccines, did not even exist when these people were, who are now adults, when they were children. Examples of that would be chickenpox vaccine, the MMR, herpes zoster, the shingles vaccine, and definitely HPV. So those things did not exist. People got measles, mumps, and rubella, and you had people that were males that were sterile after having had mumps, and you had people who had rubella that were pregnant and their babies were blind. That's the other thing to think about. How many houses, there was Perkins' School for the Blind. There were many of them all over the place. They had blind children and that also had other defects. As a result of their mothers having had rubella in the first trimester. And now there aren't many schools of that because of the MMR. Think about that. Think how many fewer blind people there are in this world because of the measles, the MMR. Okay, what are some other things? Okay, as we develop, we're more likely to develop, as we age, we are more likely to develop serious diseases caused by common infections. So you've got your flu and your pneumococcal, so pneumococcal vaccines, pneumococcal illnesses. So people 65 and older have the highest rate of complications, hospitalizations, and deaths associated with influenza. Influenza is the biggie, but we'll get into that in a minute. Herpes zoster is estimated to affect 1 million people every year. And let's see, CDC recommends the following. So these are your recommendations for vaccines. Some frequently asked questions. You can pause the video and you can look at these whenever you want. This is the available adult vaccines that people are not getting, that many people are not getting, and so that's why you had that huge number of people dying from vaccine preventable diseases. So there's your hepatitis A, B, your herpes zoster for shingles, HPV vaccines, and your influenza, measles, mumps, and rubella. And we also have meningitis vaccine, pneumococcal vaccines for pneumonia, tetanus, diphtheria, pertussis, as we talked about, and your varicella. Okay. I'm going to bring this over here. So we're going to talk for a few minutes about herpes zoster. Excuse me. On the diseases themselves, what you'll be reading in your books, that you'll have test questions on, but some of the specifics on these cards, you obviously do not have to memorize these cards, but I think these graphs are nice and give you an appreciation. Okay. This is the increase of herpes zoster. So herpes zoster shingles with age. So once you get to be 55 to 60, over 55, you start increasing, especially more so in women in this age group, more so in men in this age group, and much more so in women in this age group. So you have a very large increase in shingles in the elderly population. Besides age, risk factors for herpes zoster include medical conditions or treatments that compromise the immune system. So if somebody has, AIDS, neoplastic disease, they're on chemotherapy, they're immune suppressed, they've had an organ transplant, lupus, and as I said, immunosuppressive therapy. So the thing I wanted to mention was the complications with herpes zoster. They'll have post-herpetic neuralgia and severe chronic pain. Some people will actually get the shingles in their eyes and have serious problems with that and lose their vision. Antiviral treatments for herpes zoster do not reliably prevent it. They will actually, so if you start it soon enough after you can get the disease diagnosed, then you start acyclovir soon enough, you will hopefully decrease the severity and the duration of the illness somewhat. So serious complications of herpes zoster are pneumonia, blindness, hearing problems, encephalitis, stroke, myelitis, bacterial infections, scarring, and death. Severe, potentially life-threatening complications are more likely to develop in the elderly and the immunocompromised patients. But that doesn't have to happen. They just have to get their herpes zoster, their shingles vaccine. The other reason I love the varicella vaccine is if you get the varicella vaccine and you have the 2 shots of it, you are not going to ever get shingles because you're never going to have the herpes zoster or the varicella virus in your body that will cause herpes zoster as an adult. And that is so nice. The other thing is I have taken care of children that have had in the hospital that have had shingles, and it is not fun. You can't explain to them why they're in so much pain, and it's just a lot of suffering that's unnecessary. So here's your prevention, herpes zoster, and the prevention of the sequelae after it, their peripheral neuropathies. Okay, so now we talk a little bit about human papillovirus. It shows the cumulative incidence of HPV infection among female college students. This is just female college students. By the time since their sexual debut. So you look at when they were first sexually active till how many years out. And that's why we're doing the pap smear later on now. We're not doing it right away. We're doing it after they've been sexually active for a couple of years, or usually like 19 or 20. And we're starting birth control now without doing a pap smear or a GYN exam is not necessarily just put them on it, and actually just do a dirty urine to chest detect for GC and chlamydia, do STD screens, but not so much HPV. But it talks about the different. I don't want to spend too much time on all this stuff, but I do want it's very commonly sexually transmitted disease, and it causes a lot of cancers. And we're going to get to that list in a minute. It's estimated that 80% of sexually active women will have been infected by at least one type of HPV by the age of 50. And it talks about the Gardasil, and there's another one, but the other one doesn't actually help against genital warts. And having had to treat genital warts on young men, which is not fun for the young men or me, I really, I'm just because I want to be conscious of how humiliating it is for them, for the males and the females to be treated for genital warts. It'd be nice to get the vaccine that actually covers that as well. And HPV type 16 and 18 are the ones responsible for 70% of all cervical cancers. An estimated 11,070 U.S. women are predicted to develop cervical cancer in 2008, of whom 3,870 expected to die from this disease. Among both men and women, approximately 90% of anal cancers, 40% of cancers of the vulva, vagina, and penis, and 10 to 20% of oropharyngeal cancers can be linked to HPV. So esophageal cancer, all those are linked to HPV. And then you've got the genital warts, which I already addressed. Now you say, well, someone's just going to become a virgin, and they're, the males and the boys and the girls are going to say virgins, and they're not going to have sex, and that's how they're going to prevent themselves from being exposed to HPV, and therefore they're going to limit whether they're going to have any of these cancers when they get older. Well, they did a study, and they cultured the mouths and the throats of college students that were virginal. So they'd never had sexual intercourse ever. And they cultured the mouths just from open kissing. They were positive for HPV. So they were exposed to and were positive and had disease of HPV in their throats, which is now going to expose them to oral cancer, esophageal cancer, and other things. So anyway, just so you can't prevent it by signing a contract that you're going to stay a virgin until you get married. Because then, what if the person who you marry has it? So anyway. So this is the different vaccines, and you can read about that later. You can pause on this lecture and you can read about them. But again, only what's in your book, in your readings, and in the PowerPoint itself, as opposed to these cards, do I really want you to study for tests. This is more about HPV. Okay, now influenza. This is the biggie. The influenza remains among the leading causes of vaccine-preventable morbidity and mortality in the United States, yet its impact on the individual and public health is understated. About 5 to 20% of the U.S. population gets influenza annually, and hospitalizations and deaths due to influenza remain high. Influenza virus infections can cause primary influenza, viral pneumonia, and lead to secondary bacterial pneumonia. So this talks about leading respiratory causes of death. And if you look at this, you've got asthma, emphysema, other chronic lower respiratory diseases. Influenza and pneumonia is right. 63,000 people don't need to die. The interesting thing is, remember I talked about that the elderly, their immune system's kind of tired, and they don't, in fact, if they have an immunization, they don't often mount a good response to that immunization. So it really is important for the young people and the children around them to be immunized. They used to actually mandate that everybody got immunized in Japan for influenza. And then in recent years, the families decided they really didn't want to be forced or told they had to immunize their children against influenza. And you know how they have a lot of extended families in Japan? Well, what was happening is you had your mortality rate after everyone was getting immunized. You had your mortality rate um, in the elderly population dying from influenza-related pneumonias dramatically went down, and the patient population was protected by the herd effect. And then when you had people decreasing getting the immunizations in the schools, well, schools are the little tinderbox or the cesspool where all the sorry to say that to the schools, where everybody gets infected. My personal favorite, I think I talked to you in medical asepsis, was when the people in high schools change desks and they put their heads down on the desk. Someone puts their head down, they're sick, and they put their head down on the desk and they are, resting for a little bit, or they're coughing in their hands and their hands are touching the desk, or they're coughing on the desk or whatever, or they're touching their nose and their eyes and their face, and then they touch the desk. Then the next person who comes next is they touch the desk and touch their face. They're exposing themselves to every single germ that the prior 6 classes that day put on that desk. So and then they take it home to their family. So anyway, bottom line was that all of a sudden, when the children were not being immunized for the flu, the elderly death rate, morbidity and mortality rate started to rise. And it was directly attributed to the fact that it was better for the children around them and the adults around them to be immunized, just like it is for a newborn baby to 6 months, because you can't give a newborn baby a flu vaccine until they're 6 months old. You protect that baby from the flu by having everybody around them receive the immunization. So let me continue now. So that's what happened in Japan, and now they were rethinking it. So hopefully they've gone back to having more people get immunized. Okay, adults greater than 65 or equal years account for 90% of influenza-related deaths. So anyway, I just wanted you to appreciate that. So these are available in on this website. I have these cards if anybody wants to look at this conference that I went to and look through these cards a little bit more. And the other thing is, toward the end, I think I have a website, a link to get the current Massachusetts recommendations for treating STDs as a hyperlink for that as well. But I actually have copies of that, so if somebody wants a copy of that, I'm happy to give it to you. Okay, so this is available vaccines. This is influenza again. And it talks about contraindications and why you wouldn't. You absolutely would not. You would want the one that has no preservative in it at all given to a pregnant woman. They still can get influenza vaccine. They just cannot get the one that has the preservative in it. So they have a special stock supply held aside if a pregnant woman comes to a vaccine clinic, a flu vaccine clinic. Okay, so let's keep going now. Nursing assessment and identification of infection. If you look at recent exposure to infectious agents, prodromal symptoms. Everybody figure out what prodromal is. Prodromal is when you first come down with an illness, but before it's full blown. It's kind of you don't know what it is yet, and so they have this this set of series of symptoms before it becomes the full-blown illness. That's what prodromal is. You look for a patient's immunization history and a history of having had particular diseases. Okay, so you want to prevent the spread of disease. Primary prevention of diseases would be immunization. The primary prevention of diseases that have immunizations for them would be giving those immunizations, and that would take you right out of the chain of infection. Okay, that new chain of infection, it takes a whole bunch of people because it makes them not susceptible hosts. So you already understand that. You control the spread of disease to others. You reduce the risk of the transmission of organisms, especially like nosocomial infections such as C. diff. That's a real issue, obviously, as you've already seen in hospitals and subacute settings and long-term care settings. Infection control policies, good standard precautions used. You're going to cut infections down, and hand washing is the key, and we've talked to you about that many, many times. And comparing the hand washing, the alcohol-based, and the actual hand washing. I'm becoming more and more of an advocate of the alcohol-based, and you just wash your hands with soap and water if they're visibly soiled or it's been a while. Okay, so the next slide we have is this. Here's the baby. There's a very good nursing care plan on a child with communicable disease in peri. I can't remember what page it's in, but it will be in an infectious disease. I can look for it if anybody really wants to look at it. But your prodromal phase is kind of like an incubation period, but actually it's after the incubation period. It's really when they first start exhibiting signs of illness. A prodrome is an early symptom of a disease. Okay. Okay, so children with immunodeficiencies receiving steroid therapy, you're going to be careful of giving them immunizations, and you're going to have probably an ID specialist, infectious disease specialist, helping you with this. Or if they received steroid therapy, other immunosuppressive therapies, generalized malignancies, or immunological disorders. I have another slide. This is a prenatally acquired infection, or TORCH it's called. They used to call it TORCH, but now it's got like a whole bunch of things on it. So it's toxoplasmosis is the T, O is other, because there's a whole list and they keep adding things every couple of years. Other would be gonorrhea, syphilis, varicella, hepatitis B virus, the human parvovirus, B19, and HIV. And then R would be rubella. That's the measles that cause the blindness and can cause death. And C would be for cytomegalovirus, and causes actually a lot of these cause birth defects if a woman has them when she's pregnant. And herpes simplex virus. Well, herpes is really bad because if a baby is exposed to herpes coming down the birth canal, herpes simplex virus, you run the risk of having the baby have herpes encephalitis. And I took care of 2 babies when I was a young grad at Children's Hospital with herpes encephalitis, and it was not fun to turn off that ventilator after a week of being with the parents and having them get used to the fact that their baby was now dead. It's not a pretty disease at all to see. So they usually treat the mothers now through pregnancy with acyclovir, and used to be, and if they see any active lesions or anything, they actually would do a C-section and not have the baby come through that route. Okay. So caution for compromised children, risk for complications from communicable disease, especially varicella and chickenpox. And chickenpox can cause, you want to be very careful, they can cause encephalitis. Communicable disease, especially varicella and erythema infectiosum, EI. Risk for viremia from varicella zoster as well. Okay, let's see where else. I don't think I had a couple more things to talk to you about here. I think I talked about the contraindications for vaccinations, which would be your allergy, anaphylaxis, encephalopathy within 7 days of a DTaP, or high fever or moderate to severe reaction or seizure within 2 to 3 days of a vaccine. And I talked about which ones are live, and I did that already. Do not give MMR to a pregnant woman or the Varivax vaccine to a pregnant woman, because those are live vaccines. So do not give those to someone who is pregnant. And it's really sad, because a woman should have an MMR before she gets pregnant, because that's where you've got your rubella. Also, do not give Varivax to immunocompromised. I talked about that already. Okay, I just had some notes for myself to make sure that I did this. Okay, so we've got Fifth's disease, which you often hear about, the teacher that's taking care of the young kid that comes to school, the teacher that has a classroom of children, and then the Fifth's disease is going around, and her concern whether she's pregnant or not, early pregnant. It's an issue with pregnant women. May result in serious complications, and may result in fetal death in the second trimester. This is seasonal. It's often seen in private practice. Their rash is in 3 stages. You've got like a slapped cheek appearance, slapped face. It looks like a handprint almost. Their cheeks are very red. It appears in 1 to 4 days. Then you've got a maculopapular rash in the extremities that lasts 7 days or more. And the rash subsides but reappears if the skin's irritated or traumatized by heat, cold, or friction. So what happens is the kids go out and play for recess. They come in, they've got the rash again, and they're very itchy again. Whereas when they calm down and their temperature goes down and their skin is cool again, then they feel more comfortable and they're doing well. But you don't know they have it maybe for a while till after they've had it, and that's why you can have young people that are pregnant exposed. Roseola, that's human herpes virus type 6. The incubation is 5 to 15 days. Persistent high fever. These kids will come in and they'll be really high fevers, but they are acting perfectly fine, and they'll be like a temperature of like 102. They might be tired from it or flushed, but they don't seem to be an issue. Then all of a sudden the fever goes away, and wham, this rash appears, and that's roseola. The rash first starts on the trunk, then the face and the extremities. Rubiola, This is regular measles. This is secretions, droplet transmission, incubations 10 to 20 days. So you think about how far you have to be out, isolated. And they would quarantine these folks. If anyone in the family had measles, they'd quarantine the house years ago. Incubation period would be 10 to 20 days. Communicability for 4 days before to 5 days after the appearance of the rash. So you didn't have the rash yet, so you didn't know you were contagious, and you were exposing you're exposing this disease to all the kinds of people during that period of time. And you look at the Koplik spots appeared 2 days before the rash. There's a good photo in look up Koplik spots, and there's a good photo in Perry about that. They're like little whitish pearl like vesicles inside of the mouth. Measles, this is the regular measles, as I said. They get a rash. You can have meningitis, blindness, deafness, and according to the World Health Organization, about 900,000 deaths worldwide in children less than 5 years old related to measles. So that's an awful lot of children dying in the world under 5 years of age because of this disease when we have a vaccine to prevent it. Mumps, we talked a little bit about. It's transmitted via droplet or direct contact. Incubation periods 14 to 21 days. Fever, headache, malaise, followed by parotitis, and it can cause the orchitis, and meningoencephalitis. But that's that worry about the male being sterilized is from the orchitis. That's the testicles become inflamed and become affected. Next would be, I'm sorry. I'm so sorry. I didn't advance the slide. So this is your orchitis and your meningoencephalitis, and this is the course of the illness. But this is the males will become sterile if they have the complication of the orchitis. Then you've got pertussis, which we already talked about before. Droplet or direct contact, short rapid coughs followed by a crowing or a whooping sound. Complications would be pneumonia, and that's the usual cause of death. And that's why that's a big push to give Tdap to all pregnant women, and give Tdap to now everybody who's getting their tetanus shot renewal. They need to have it documented that they had Tdap. Okay. Now, this is the bad culprit here too, is German measles, and the transmission is direct contact or indirect contact with article freshly contaminated with nasopharyngeal secretions or blood, stool, or urine. So every orifice of the body can pass this one on. Incubation period is 14 to 21 days. Complications are rare, but the greatest danger is teratogenic effect on fetus, and that would be the blindness. So that's it. Excuse me, it's teratogenic effect. It's really dangerous to pregnant women. They often have a spontaneous abortion. If the pregnancy does survive, the child will have issues with blindness and deafness. So can you imagine being deaf and blind? That's really tough. 20,000 infants affected annually prior to the vaccine. So that's why you had 20,000 infants born every year that were blind and perhaps deaf, and that's why you had all these schools, Perkins School for the Blind. There were several in the state of Massachusetts. They were all over the country, and now it's nice they're going out of business. So, scarlet fever. This is group A, hemolytic streptococci. It's transmitted by droplet to direct contact, incubation period 1 to 7 days. Complications are carditis, peritonsillar abscess, and glomerulonephritis. So that's why we treat positive strep throats. You get over them, and most people do fine. It's like 0.1% have a risk of glomerulonephritis, and other certain percentage of them will have the other complications, so that's why we treat it. Pharyngitis or tonsillitis, no upper respiratory systems is usually common. You don't usually have nasal congestion like you do with a cold when you have positive strep. It's just the throat or the tonsils are affected. If you have a positive strep culture, or if the rapid strep test is negative, I always send a backup culture to the lab. Unless I decide I'm going to treat anyway because it's such a horrible pharyngitis or tonsillitis that I'm going to treat it, then there's no reason to, because it isn't going to change. You're going to make sure that you treat it with an antibiotic that's going to take care of strep if you're going to treat it all. A strep rash, if you feel it on the abdomen, it feels like sandpaper. And the kids usually come in complaining of a headache, fever, and stomach ache. Sometimes they don't even complain of a sore throat, but the headache, fever, stomach ache, the rash on their belly, and just they want to have their head down. They really have their head down on the examining table when you walk in the room. That's classic. It's nice that Pen VK, it's very organism specific. It's cheap. It doesn't blast the patient with a broad spectrum antibiotic, and you can usually take care of that. The thing you don't want to do is if you give amoxicillin, you don't want to give it to teenagers that you think might even have mono, because then they'll have a mono-related ampicillin rash, which is really very uncomfortable. So usually I will go with treat with Zithromax if I have an adolescent and I'm concerned. And if I get a rapid strep that's negative, and then if I got an adolescent that might possibly have mono, then I'm more likely to treat with Pen VK or Zithromax. I'm not going to treat with amoxicillin. The rash, the scarlet fever rash, this is how it progresses, and you can look at that yourselves. Conjunctivitis is common. In the newborns, you see it. In maternity, it's caused by chlamydia, gonorrhea, or herpes simplex virus. In infants, it may be a sign of tear duct obstruction, though usually that's when there's no yellow or greenish colored pus or exudate from the eyes. The eyes don't tend to get crusty and goopy. It's really they just have extra tears, because the tears can't go down the lacrimal duct into the nose. So when you cry, your nose waters because it goes down through the lacrimal duct, and that's why your nose waters. So that duct is closed with them. So it's a matter of waiting till it either opens up on its own, or you actually have it probed by an ophthalmologist. So it's children it causes, or this is other ways of getting conjunctivitis. This would be just a viral or allergic or foreign body or bacterial. Bacterial is the most common, and that actually you have to treat, and they're not supposed to go back to school or be around other children or go to daycare till they've been on the antibiotics for at least 24 hours. If the child also has a ear infection, it's very common if you have conjunctivitis on one eye that actual ear on the same side, you always check that carefully because they might have an ear infection. If you treat them with oral antibiotics, you don't really have to treat with the eye ointment, and it's not fun to get eye ointment into a kid anyway. So. All right, now I've got a couple more things for you. Recommended website. It's kind of neat if you want to go to it, but you don't have to. That's not something you have to do. These are emerging infectious diseases. You've got the West Nile virus, Legionnaire's disease, Lyme's disease, MRSA, VRE, hantavirus, pulmonary syndrome, Ebola, and Marburg virus. These are pretty awful. I don't know if anybody's ever read the book Hot Zone, but it's really pretty impressive way to get. It's an older book now, but you've probably heard about these diseases, and if you look them up, they're pretty dramatic. Other diseases to add to this list are H1N1 or SARS. That's the flu-like illness presenting with fever and cough. And the World Health Organization issued a global warning on that one in March 2003. The novel H1N1 swine flu, that was the June 2009 one that I talked about earlier. The global pandemic was underway related to the rapid spread of the virus, April to June 2009. More than 70 countries and greater than 1 million people infected, and that happened in a very short period of time, from April to June, April, May, June. So 2 months, you went from 3 people being infected to over 1 million people being infected in 70 countries. I was trying to find that information on the conference that I went to on that, but there it is. I did actually document it in a lecture, so you have it. Okay. Back here to Lyme. You've all heard a lot about Lyme, and better to treat in the beginning than to be sorry later, as my motto. So if I have any question that it was longer than 20, like longer than 48 hours that tick was attached to the patient, I'm very strongly likely to treat, or I am going to treat. Okay. The hantavirus is a 50% mortality, severe cardiopulmonary disease. It's a rodent-carried virus. The Ebola and the Marburg, those are fluviviruses. They had 20 outbreaks. There have only been 20 outbreaks since the 1960s. The mortality rate of getting one of these diseases is 90%, and both have been prepared as biological weapons. There you go. The West Nile virus, usually flu-like illness with headache and fever, less than 1%. Severe signs and symptoms including meningitis, and Legionnaire's disease is that pneumonia that's a gram-positive bacteria, and that was, I believe, 1976 that one came out. So these have all been relatively new. Now, I'm going to go back down to a little bit more. Some issues you have to consider are travel and immigration. You have acquired immune disease. And there's in Lewis, I believe there's a care of the patient and a care plan in there, taking care of AIDS, HIV/AIDS syndrome. Tuberculosis you're going to be learning about next year, so don't worry too much about that. And vector-borne diseases would be things when you travel, like malaria, yellow fever, dengue virus. They cause significant morbidity and mortality throughout the developing world. And there is a website you go to on the CDC. You'll go to CDC travel immunizations, and it will tell you what you plug in what country you're going to go to. It very nicely tells you anything that currently is going on in those areas and what you should be being careful of, and what immunizations you need to take ahead of time, and what disease you need to take preventively, such as malaria medication, which you have to start taking before you go and continue taking for a while after you come back. That's what people do, is they leave the country and they stop taking it, and you've got to take it for like a month after you come back in order to prevent malaria. So anyway, so this is your CDC .gov travel, and I think a friend of mine was going to South Africa, so for a semester abroad for school, and so I saw her in private practice, and we went through all of the immunizations and medications she needed to take with her, and we ordered all the immunizations. She came back with them, and we gave them according to how they're supposed to be given. So that was a good way to prepare her for her trip. Diarrheal diseases, this is a list of them. Diarrheal diseases kill more than 4 million people per year in developing countries. In the U.S., 400 children die per year from dehydration being the main factor for morbidity and mortality. Especially if you're in PD now, but for everybody to remember, if you have a baby, they have greater surface area per body weight, and so when you have that patient having dehydration related to vomiting and diarrhea, which means you can't get fluid into them because they drink it, they throw up, and if they get it into them and they're also having diarrhea, so they're taking more fluid out, you're screwing their electrolytes are being screwed up, they're getting very dehydrated, and it's a medical emergency. And particularly if you then add fever into the mix, they're even going to dehydrate faster. So that's a medical emergency. They need to go to the ER, and they need to get an IV, and they need to be fluid resuscitated. Again, with your diarrheal diseases, the portal oral ingestion of infected food usually. The stomach acid usually protects if they have decreased gastric acidity or disrupted normal bowel flora from antibiotics or surgery or AIDS, then you've got an increased risk of having all these illnesses really, really affect you. And the next thing would be sexually transmitted diseases or infections. Human immune deficiency virus or AIDS. You've got syphilis, gonorrhea, chlamydia, cytomegalic virus. These are the most common, and then add to those your Hep B, your Hep C, your herpes simplex, your human papillovirus, and your cankeroid venereal ulcers. And syphilis is on the rise, and all kinds of good things. So there is look up for a table in your reading that's related to diseases classified as STDs or STIs. They'll say sexually transmitted illnesses as well. Diseases acquired by sexual contact with an infected person, and the STDs are the most common infectious diseases in the U.S., epidemic in most parts of the world. Okay, now here is where the website is for you to go to get the current Massachusetts Department of Public Health Division of Sexually Transmitted Disease Prevention. I think the latest ones are 2012 Sexually Transmitted Diseases Treatment Guidelines. They upgraded it in 2012. I have copies of that, but if you go to the website, it might actually say that there's a newer one, but they usually only update it every couple of years, so I don't think they've done that yet. And I will have copies of that available in my office if anybody would like one. But you can, as I said, you can go to this website and print it out. So now what if you have somebody at home being taken care of household members? You're going to have to do a lot of teaching. You've got patient hand hygiene is always important. High hand hygiene for the household members as well as them wearing protective barrier and precaution, taking precautions against. So again, you've got to start. Teaching is crucial. How to use protective, your PPE, personal protective equipment. Patient teaching is huge, and all caregivers need to know and practice standard precautions. So your nursing management, you want to prevent transmission, teaching about infections, the infectious process, teaching that chain of infection, controlling fever and discomfort, and potential complications. So I think this is just about the end of your lecture. And this is a book that I did read. It's an older book now. I was riveted, absolutely riveted. Of course, then you'll definitely classify me in the nerd category, but it really was. And it's nonfiction, and that's why another reason why it's kind of tough to read. But I hope you had a good snow day and you have the weekend to review this lecture. And this lecture will have questions on the exam on Monday on it. Of course, now they're forecasting snow for Monday, so maybe we'll be making adjustments again. And I'm lecturing on Monday, so maybe I'll be doing this again on Sunday night if it looks like there's an issue. You take care, be well, and try to get some rest and stay safe.